In this presentation, a linear fracture of the mandibular angle is treated with a 1.0 mm thick matrix mandible malleable miniplate positioned on the oblique ridge as described by Schompe. The malleable miniplate has the same dimensions as the standard miniplate but is easier to adapt, which facilitates contouring to the complex anatomy of the mandibular angle. The learning objectives of this presentation are the principles of load sharing across the fracture and the correct application of the 1.0 mm thick matrix mandible malleable miniplate at the oblique ridge of the mandibular angle. The matrix mandible plate and screw system can be used for all mandibular trauma and reconstruction indications. All plates feature conical locking technology for a reliable screw-to-plate construct. The plates are available in thicknesses of 1.0 to 2.8 mm. In this exercise, a 6-hole, 1.0 mm thick malleable miniplate will be used. Locking and non-locking screws are available in diameters of 2.0 to 2.9 mm. In this exercise, 2.0 mm non-locking screws will be used. One screwdriver blade fits all the screws. All of the screws can be used with all of the plates. All of the plates, screws and instruments are color-coded. Loading across a mandibular angle fracture leads to tensional forces at the oblique ridge and compressive forces at the lower border. These tensional forces can be borne by a 1.0 mm thick matrix mandible malleable miniplate positioned on the oblique ridge of the mandible. The compressive forces may be borne by the fracture surfaces, particularly at the lower border, provided there's an intact bony buttress. Therefore, load sharing takes place when the load across the fracture is shared between the fixation system and the fracture surfaces. Routine diagnosis of this type of fracture should include pre-operative X-rays, taken in two planes at 90 degrees to each other, such as a panoramic and a PA view. CT scans may also be used. In a clinical situation, access to this fracture would be through an intraoral approach. If there is no erupted molar to be removed, or there is a fully impacted molar in the fracture, an incision along the external oblique ridge is made. If there is an erupted molar that will be removed during surgery, the mucosal incision should be made so that closure over the extraction site is facilitated after fixation of the fracture. The instruments needed are 2 bending pliers, the 1.5 mm drill bit with 6 mm stop, and a self-holding screwdriver. If a molar in the fracture site requires removal, it is removed prior to placing the patient into MMF. Open reduction and stable internal fixation in the dentate patient begins with fixation of the occlusion. For this exercise, Ernst ligatures have been selected. However, it should be noted that many surgeons prefer MMF with arch bars because of the increased stability. A 6-hole, 1.0 mm thick matrix mandible malleable miniplate with center space is placed on the oblique ridge of the mandible along the ideal line of osteosynthesis as described by Schompe. The plate must allow for at least 2 screws in each main fragment and sufficient distance between the fracture line and the closest screw hole. In this exercise, non-locking screws will be used. Locking screws can also be used, but to do so one must use a drill guide that centers the screw within the plate hole. The plate is contoured with bending pliers to match the anatomy. The first hole is drilled monocortically posterior to the fracture using the 1.5 mm drill bit with 6 mm stop. The drill should be held at approximately 90 degrees to the plate and bone surface. A 6 mm long 2 mm screw is inserted, but not fully tightened, to allow for any plate adjustment. The screw placed into the proximal fragment allows the condylar bearing fragment to be reduced with the help of the plate. The second hole is drilled anterior to the fracture. A 6 mm long 2 mm screw is inserted. The remaining screws are inserted. If the posterior hole is inaccessible due to occlusion, a screw can be inserted there after the MMF is removed. Access to the posterior screw hole is provided by opening the mouth. The remaining plate hole in the proximal segment is filled with a screw which is fully tightened. The fixation of the mandibular angle fracture is now complete, and the mandible is functionally stable. The post-operative X-rays show the clinical result. With this type of fixation, a gap at the inferior border is acceptable. As the functional load starts acting on the mandible, the gap will close. One alternative is a 1.25 mm thick crescent plate along the lateral aspect of the upper border and a 1.0 mm thick mini plate along the lateral aspect of the lower border placed using the transbuccal instrumentation. Here, 2.0 mm locking screws were used. When this technique is used, a gap at the inferior border is not acceptable, as the plate at the inferior border will prevent the gap from closing. This presentation has shown the principles of load sharing between the fixation system and the fracture surfaces in a simple linear fracture as described by Schompe, and the correct application of the 1.0 mm thick matrix mandible malleable mini plate at the oblique ridge of the mandibular angle.